Dr. Shields is battling a case of laryngitis, so we are going to make this as much mic'd as possible. So thank you all for your patience. Let me start off with you, Dr. Legge. Last year, we focused on the fundamentals of Parkinson's care. And as the disease progresses for all of us, what are the most challenges that you see with patient care in this area?
Number one, I want to just say thank you for having me again this year. This is, as we've said, it's our second year getting together. And, I'm inspired by the community, the stories we share together, and the resilience of our patients and their families. And that's really what this is about. And we navigate this together. So, these events are, I think, reinvigorating for the community, but for us, and it's an honor to be a part again. The challenges for Parkinson's is, last year we talked about kind of basics of care. This year is more as Parkinson advances and some of those complexities that occur. And I think some of the biggest challenges are those to quality of life, and that is not just the movement symptoms or the motor symptoms like tremor or stiffness, balance changes occur, but more we see non-motor symptoms. When I say that, I mean things that aren't necessarily related to the body's movements like stiffness, tremor, or dexterity, but things like fatigue or cognition, thinking, memory, blood pressure and bowel movements, swallowing. These things may or may not be impacted, but we see more non-motor symptoms that can drive real issues with quality of life. And that requires more individualized care, and there are many options that abound, and that makes it effective in addressing quality of life symptoms.
I love the fact that you are looking at a larger picture than just the basics, but most people assume that carbidopa-levodopa is the thing that will take care of everything. While that is partially true for some of our symptoms, where does that fall short in patients' understanding of the disease?
Yes, so carbidopa-levodopa is the gold standard. So it is the baseline medication for the vast majority of motor symptoms for Parkinson's, but it does not necessarily help the non-motor symptoms. So when that medication starts to fall short, we add on adjunctive medications, or add-on medicines we call. So if there's issues with excessive movements, fidgety movements called dyskinesia, we have adjustments we can make to carbidopa-levodopa, but we also have specific medications that could be added to the carbidopa-levodopa to help the dyskinesia. We have additive medications that can extend the duration of how well the carbidopa-levodopa works. And we have medications designed for hallucinations if that becomes an issue, blood pressure if that becomes an issue. So again, as these are complex symptoms that could develop, fortunately, as I mentioned, there are options, and many options abound, so it's about that personalized approach.
How do you prioritize which symptom to address as a physician when you hear us coming into your clinic and saying, I'm having these? Is there a certain prioritization? And please elaborate.
Absolutely. So my approach is to listen to the patient and others in the exam room. That's caregivers, family, loved ones, team approach. Get a history, figure out what's going on at home, how the medication regimen is working. And we go through a review of symptoms to identify if there's swallowing issue, blood pressure, balance, speech issue, etc. And then I kind of rank it mild, moderate, or severe, small, medium, large, and then we prioritize what the patient is most bothered by. And then I balance that with what I think may be a safety issues, if there's falls or swallowing issues or hallucination issues. So that's balanced with what the patient is most bothered by.
And I like that how you say that come in and talk to me about what the symptoms are. I don't know about you all, but I find it extraordinarily helpful when I come in, I write down in a little 3x5 index card, which I learned from my father, the symptoms I've had since my last appointment, and rank those. So I'm able to tell my movement disorder specialist if I only have a short boon of time. Thankfully, she's generous, but I have that. So I think that really helps for those, because also sometimes I'm going to forget, or I'm also nervous and I'm not going to be able to share. So I like how you talked about the different ones and which are the most challenging. What are some red flags that suggest that maybe it's time to adjust the medication or go a step further into other types of care for Parkinson's, like DBS or other ultrasound choices?
So whether I look at it as red flags or just kind of rising clinical concern that I'm seeing patterns, or we're talking about patterns in the exam room of the carbidopa-levodopa medication, for instance, seems to not be working as strong or lasting as long. That's motor fluctuation. So in between doses, the symptoms the dose wears off. We're approaching that next dose, but things are wearing off too soon, and tremors or symptoms come back. There's motor fluctuations or dyskinesias. There's a sudden change in balance. There's a sudden emergence of hallucinations or kind of abnormal behaviors that's new and different. Sudden changes in movement, behavior, these get my attention. Falls and swallowing changes. So we intervene on those more quickly. And as people probably are aware, I'm very checklist driven. So fortunately, we try and hit those same topics every time. Just may not be an issue now, it may not ever be an issue, but it's important. We're always trying to talk about those abrupt changes that can occur.
And I like the description, the abrupt changes, and those are the ones that we really need to make sure that we're bringing up to our doctors, where those can get more immediate attention rather than something that just continues on. Everyone shows up saying, "Oh, I'm fine," but making sure that you're really honest and open with your doctor. That's the only way you're going to be able to get treated better, and that your doctor is going to be able to keep a more accurate picture of your journey. So briefly mentioned DBS. Dr. Shields, I know this is a very generic question, and I'm sorry for tossing it to you, but when should someone consider DBS?
I'm sorry again for my voice. You should consider DBS when Dr. Legge says it's time to consider DBS.
Great answer.
He knows your Parkinson's disease the best. He knows what DBS target is going to work for you. He knows when your medications are not as effective and when you're starting to experience fluctuations. And he's going to talk to you about it early and throughout the process. And hopefully by the time it comes to pass that you need DBS, you'll be ready and well-versed in the subject, and it'll be less intimidating.
Thank you. And you said that Dr. Legge is going to be the best person to determine that. So let me turn it back to you. Are there things that jump out at you as someone that you need to say, okay, it's time for you now to go talk to Dr. Shields in consultation with me?
Yeah. Yes. So some of the core indications for deep brain stimulation or focus ultrasound are generally when the medications are falling short. So in particular with the movement symptoms, because deep brain stimulation does not help the non-movement symptoms. It does not help speech or balance, necessarily cognition or swallowing. But if there's tremor, in particular tremor, but the medication, is carbidopa-levodopa, when I mention medication, is not holding that tremor at bay, and there's a lot more tremor and or dyskinesia, that's an indication to consider DBS. And then we really want to think about how the medication's working for that patient. If the medicine has a distinct good response, carbidopa-levodopa, but wears off early, so we see a positive medication response. On the other hand, we know that if the carbidopa-levodopa kicks in and has a wishy-washy response, DBS will have a wishy-washy result. So we want a distinctly positive response to carbidopa-levodopa, motor fluctuations and or dyskinesia. And we want to have good balance and intact cognition. And so, in part of the process of thinking about DBS, patients need to have, we do not, Dr. Shields does not perform brain surgery on someone who has significant psychiatric issue or dementia issue. That surgery could make patients worse. And so we want to intervene on a window of time that makes sense. And that's when there are movement symptoms, fluctuations or dyskinesias, tremors. There's a good response to the medication, and we've got intact balance and cognition, so that's a window of time. Maybe a few years, perhaps, but I think that's a conversation we're always thinking about.
That's really great to hear, because I would think early on when I was thinking about DBS that there were just a couple of boxes you had to check with your doctor, and it was a kind of not a black and white situation, but it's very, very thoughtfully and intensely viewed and scheduled. Dr. Shields, along that line, DBS is obviously invasive and it's brain surgery. Can you maybe talk about the steps from consultation and when you're evaluating to the recovery aspect of what DBS entails?
So you're going to be referred to my office from Dr. Legge's office. At your initial consultation appointment, we're going to talk about what symptoms respond best to dopamine. And I'm going to counsel you on, what I think DBS can help with your Parkinson's disease, and similarly, what I think DBS may not help with your Parkinson's disease. And hopefully Dr. Legge has already talked to you about that also. In people who are going to get subthalamic nucleus stimulation, I refer for neuropsychiatric evaluation. That's to make sure that you don't have any underlying dementia or psychiatric illness that may be made worse with stimulation. Then we will get a set of labs and brain images to make sure that your brain is safe to undergo DBS surgery. It's extremely rare that you do not pass that step. And then we will schedule your surgery after that. If you have a cardiologist, you'll have to get clearance, and if you have significant medical issues, you'll have to get clearances for that. On the day of surgery, you'll come in to the hospital, you'll meet the team, you'll be awake during surgery most likely, and that's so that we can test your lead and make sure it has efficacy. We kind of give you the same medication as if you were having a colonoscopy. So everybody who's luckily had a colonoscopy knows you kind of remember it, you kind of don't, and you wake up and you kind of remember some details, and that's kind of how DBS surgery is. So we give you the colonoscopy medication. We put some bone screws in your head and train a computer where in space your brain is. And then we do a series of recordings to see and check that we are in the correct place before inserting the final wire. We also do a series of checks to make sure that you don't have any side effects where we're going to put the wire. We put the wire in, we test it again, we make sure that everything works to your liking and to the company. The lead company is also in the room, and they make sure that you have a good threshold and everything. And then we put you to sleep, and we close everything up. Because of the way insurance companies pay for these surgeries, it has to be done in 2 stages. So the first stage is we put the wires in the head. The second stage is 3 days to a week later, where we connect the wires to a battery that goes in the chest. That is a great insurance question, which I still do not to this day understand why. Basically, the battery is the most expensive part of the procedure. And if they don't bill it separately, the hospital doesn't get paid for the battery, and they lose money on the surgery. So it's basically standard of care that these are done in 2 surgeries, which is unfortunate, but that's my soapbox. So the second surgery is general anesthesia. You go totally asleep. It's a 30-minute surgery. We connect the wires from here. We tunnel it underneath your skin to a battery in your chest, If you've seen people with pacemakers, it looks exactly like that. After that surgery, you'll see me in my office in 2 weeks. We'll check your incisions, and then Dr. Legge will see you 1 month after surgery, after your leads were implanted, to do your initial programming. Programming takes anywhere from 3 to 6 months, depends on how long you've had your symptoms before, how tricky your tremor can be, things of that nature. But you work with Dr. Legge closely, and Dr. Legge and I keep in close contact.
Thank you. That's extremely detailed and really actually very helpful for people considering it. It sounds like a lot, but actually having gone through it, it actually really, it's choreographed extraordinarily well. And the relationship that you two have makes it even better for those who are going to be considering it. So thank you for really being detailed in that. Dr. Legge, back to you then. What are ways then that post-DBS that you are looking for to see how successful, if you can determine the success of it, how do you counsel your patients going forward after a thing like that?
You know, when we look at the studies, easily over 90% of patients that have deep brain stimulation done, when you've gone through a good patient candidacy selection and had that well choreographed, outcomes are generally quite positive, and 90% of patients indicate they would have the deep brain stimulation done again, because it does help such significant quality of life symptoms. Again, with the motor symptoms, in particular, patients that have tremor do the best with deep brain stimulation. So we generally do see a lot of reduction in what we call off time, that is when that carbidopa-levodopa is not working and there's more symptom time throughout the day with tremors or stiffness or slowness. We see that go down significantly with deep brain stimulation. Dyskinesias can decrease on the order of 50 to 75%. And we can decrease medication, sometimes that magnitude as well, by 50 plus, 70 plus percent. Because at that point, the pacemaker is controlling a lot of the symptoms instead of the medication. So you're able to reduce the amount of pills, and by doing that, you're reducing a lot of the systemic side effects. So if the carbidopa-levodopa is causing constipation or dry mouth, we see a lot of alleviation of those symptoms, which is very exciting. And but as Dr. Shields was indicating, this process of honing in on the patient's best setting it can take a few months to really zero in on that. But it's an exciting time for patients. A little bit of trial and error as we get going down that runway, but eventually we take off.
And that trial error is really important to keep in mind because, it took probably 3-4 months for mine to get to a point. We talked a lot about DBS, but there's the other one, the MR-focused ultrasound. I'm going to try and save your voice. But can you explain what that is? And is that a better, different option than a DBS, or can they be done one after the other?
No, it's a wonderful technology. So, when I talk to patients about MRI-guided focused ultrasound, it's a good procedure for Parkinson's for tremor better than dyskinesia. It does work better for tremor than dyskinesia, and right now it's just for unilateral, meaning on one side of the body. So if the patient has symptoms on both sides significant, we're only really going to get relief on one side of the body. Right now it's not FDA approved to have focused ultrasound done on both sides, so we only get one side of symptom control. It works better for tremor than dyskinesia. It is incisionless, and so it does not require general anesthesia, but it doesn't require any anesthesia necessarily, and no cuts are made. It's done through just shaving the hair, ultrasound gel. There is a halo installed, but the ultrasound beam is applied, and they're able to perform tremor surgery through a sound wave entering the skull and disconnect the tremor circuit in a way to control symptoms. And it's generally instantaneous, although there can be a building effect, but it's irreversible. I do look at this as causing a stroke a very targeted, precisely targeted stroke to disconnect the tremor circuit, in a manner of speaking. So there's no hardware and no programming, and a more instantaneous result, but it's not titratable. I can't go up or down on the tremor control. What's done is done. And only one side of the body can be performed. So if we are talking and we think the deep brain stimulation makes more sense, there's more symptoms. If the patient may be more symptomatic on one side or have perhaps a contraindication or a reason, I should say, not to undergo deep brain stimulation, then focused ultrasound could be a reasonable substitute. On the other hand, many patients are not interested in having invasive brain surgery, even if it is minimally invasive. It's still having hardware in two separate surgeries. So this could be appealing to those that don't want to go to a more invasive approach for their tremor. The last thing I would say about focused ultrasound is, while data is still coming out about long-term outcomes, we do see that it's not as potent in the long run as deep brain stimulation for symptom control. Roughly speaking, the tremor circuit starts to regrow, and so it grows around that lesion that the neurosurgeon caused. And whereas with DBS, then you can just crank up the power of the electricity to compensate as that tremor gets more strong. You rarely, but it can be done, you can go back in for further ultrasound procedure, but it comes with increased risk of side effect. You asked, and I'll say one final thought. You can have MRI-guided focused ultrasound and then deep brain stimulation, but you cannot have deep brain stimulation and then MRI-guided focused ultrasound. That would be too much procedure on the brain, and the MRI can't be targeted with a wire present. And so there's an order that could have to be done and obeyed. But generally speaking, DBS is more potent. Ultrasounds better for one side of the body with more tremor issue.
Thank you, and that's actually, especially your last thought was really helpful for me to understand that you can't have DBS than the MRI guided. Thank you. Dr. Shields, going back to kind of like the basics of DBS, what are some of the realistic benefits and limitations that someone might expect when having DBS performed?
I think the big thing is, what I try to tell patients is that anything that your dopaminergic medications really help with, DBS is going to help with. The things that DBS is not good for are, like Dr. Legge said, non-motor symptoms, orthostatics, gait, problems with freezing, bradykinesia sometimes. Those are not necessarily good DBS targets. Things that are good for targeting with DBS is dyskinesias and tremor are really good.
Great, thank you. There are obviously challenges and issues regarding Parkinson's going outside of the surgery aspect. What are you, as a physician, most excited about that's on either right now or on the horizon that you think people with Parkinson's and, of course, their care family that you are most excited about for now?
So we've had a lot of increases in technology in just the past few years with Parkinson's research, a lot from the Fox Foundation. And, for instance, even with current therapeutics now, when we're talking about deep brain stimulation, there's new models of deep brain stimulation out. And I should say I'm not endorsing one particular drug company or brand of device or another, but in 2025, the FDA approved for Medtronic their BrainSense, adaptive DBS. There's been approval for a new form of levodopa, a newer form of levodopa through infusion form. It's delivered subcutaneously through a pump device. So for patients that have a lot of medication demand throughout the day, this can do some of the heavy lifting. There are new wearable technologies in terms of trials. A lot of exciting advancements. A couple that get my attention are some of the stem cell replacement trials that are moving into later stages. Some of the anti-inflammation trials to reduce brain inflammation and slow progression. Gene therapy trials. Small molecule trials. Antibody infusion trials. There's a lot going on that's exciting. So this is about not just what's to slow progression down the road, but actually for therapeutics that are available now. It's an exciting time.
Dr. Shields, I don't want to press your speaking too much, but can you succinctly talk about what excites you most about now or coming in the future for types of surgery or care that you provide?
Yeah, so I think, going along with Dr. Legge was saying is the stem cell genetic trials are really exciting. Those will require, or those historically have required some sort of brain infusion. The trials are up and coming, and I think it's going to be great whenever they figure it out, and it seems like they get closer every day.
Thank you so much for that. What are the basic imaging tests for Parkinson's disease, and are there any new tests on the horizon?
So actually, Parkinson's disease is still a clinical diagnosis. There is no one definitive test for Parkinson's disease. And it is tricky to diagnose. I will say, there's, based on just clinical exam, there's about 70% accuracy in exam. So we do like to try and have tests that support the diagnosis, not prove or disprove. That test does not yet exist. So an MRI scan is always very helpful to establish what we call kind of baseline structural imaging of the brain to make sure there's no tumor or stroke or bleeding or malformation or water on the brain. Outside of that, we do use, there's DAT scan imaging, DAT scan imaging, which is done through radionucleotide. There's an IV placed through the vein, and then a special form of dopamine is delivered through the IV infusion. And after a period of time, a few hours, the patient undergoes a special CAT scan, and we look to see how the brain handles dopamine. And if it can handle dopamine well, that does not show Parkinson changes. If it's abnormal, that supports there may be Parkinson. And it's about 70 to 90% accurate. And there's a newer test called an alpha-synuclein punch biopsy. And that has been out for a couple of years now. It does turn out that the chemistry changes of Parkinson's can frequently be detected in the nerves of the skin, the cutaneous nerves of the skin. So that was the trick for the biopsy, is by taking a very small sample of skin from the back of the neck.
Is that the three punches?
That's
neck,
correct.
the hip, and
the back of the neck, thigh, and calf, and it's stained in a lab in Scottsdale, Arizona. And they send us a report back in a few weeks, and it's about 95% accurate. But, as I've mentioned to some of my colleagues, if we have done and approved, 60 plus biopsies, and it has 95% accuracy, 1 out of 20 may be spurious, a false positive or a false negative.
Thank you.
And so we cannot hang our hat on this DAT scan or this biopsy. We have to take it holistically with exam, history, labs, imaging, biopsy, and we are allowed to change our diagnosis over time. And that's sometimes what happens.
Absolutely, and I think that's also something to keep in mind, is that diagnosis can change. I can speak from experience that punch that he mentioned is not painful, and it's really not invasive at all, but is something that if you and your doctor have talked about is an interesting option. We've talked a lot about medication and surgeries, but we haven't really talked about other things that outside of those can be beneficial for those of us with Parkinson's. Supplements, exercise, etc. Can you expand a little on those possibilities and how they play a supportive or even an equal role in the care of a person with Parkinson's?
Absolutely. I think the holistic approach is best. With the patient at the center of the model, and we think about medications helping, surgery helping. But I also think about physical therapy, occupational and speech therapy groups, community groups like Parkinson Resource Organization or Eisenhower's PD and Motion Exercise class, the Songshine Choir Group, Rocksteady Boxing, and we've got community support here. We've got faith and partner groups. We have social welfare clubs. These are all supposed to improve quality of life, which is really what the game is. And so I'm a believer in diet and exercise, judicious, not too much, not too little use of medication, and all of these other services and support to put the patient first.
Is there a diet that you suggest that we take?
I think there is growing evidence be it for Parkinson's, Alzheimer, MS, stroke, cancer, kidney failure, heart disease. The more plants we eat, the better. So I do think more plant-focused diet is probably best, and there's evidence for this. In terms of I don't endorse one diet or another, but I love the MIND diet. I think this is a very helpful diet for most Americans. It's a blend of a Mediterranean-style diet, which is a very plant-heavy diet, but also a heart-healthy diet. So we're trying to eliminate processed foods and more salt issues. We're going towards more lean proteins, chicken and fish, but nuts, oils like olive oil, lots of plants, vegetables, some fruits. Fruits have a lot of sugar. But this slows cancer, slows Alzheimer, perhaps Parkinson's, reduces stroke and cancer risk. So it's a flexible diet. I do think diet should not be punitive. I think I said last year, as far as I know, we're only here once. And food is a pleasure for patients. So, but I think the more we focus on that clean nutrition, we get better outcomes.
And so it's okay to indulge in a little ice cream here and there, is what you're saying.
As far as I know. I hope so.
I'm going to tell my wife that it's okay.
Or chocolate.
Okay, I agree with that. Are there any side effects or issues having an MRI-focused ultrasound that people should be aware of if they're thinking about that procedure?
It's pretty low risk profile, just like DBS surgery. So I think the biggest risk is long-term paresthesia, meaning numbness. And even the risk of that is 0.9%. Almost everybody who gets MRI-focused ultrasound will get some transient paresthesia. It's because of where they do the lesion, but the brain figures it out and it comes back on average 2 to 3 months after the focused ultrasound.
That's great, thank you. I know that a question that I would have too if I was going to go there. Dr. Legge, you mentioned some language which you were great in explaining quickly, but you mentioned subcutaneous pump. What is that, and how quickly can we? Is that available now?
Yes, it's available now, and it's been FDA approved for, I believe, about 2 years or ballpark. And the remarkable pharmaceutical heavy lift was figuring out how to make tablet carbidopa-levodopa activate subcutaneously through alkaline phosphatase infusion. Enzyme activates this medication that's infused through a tube that's attached gently under the skin. And this infuses throughout the day your dose of phos-carbidopa, phos-levodopa, and it's then activated into levodopa through the body's own enzymes chemistry. And it does require some training, and for patients that are having, I think, more of the motor fluctuations, or what I may term as heavy pill burden. We're taking several doses multiple times a day, and we're really having a hard time staying on the clock. And we may be having a lot of oscillations or fluctuations throughout the day. This starts to make sense. And it may be a temporizing measure, perhaps before something like deep brain stimulation, or maybe an answer for those patients who are not a good candidate for deep brain stimulation. The subcutaneous infusion form is, I think, an advancement over a more older form called the Duopa pump. And that is a difference. That is through tube that's delivered to the small intestine through a feeding tube. The Vyalev pump through the subcutaneous is just through the skin, and so less invasive.
That's great, because my father had the duopa pump and it was challenging. So this new one, it sounds like it's not really isn't cumbersome, isn't something that people really will have to hide or.
No, and I think the company does an excellent job with Vyalev to provide. It is about the thickness of 2 cell phones. The pump itself, but patients who have diabetes or insulin infusions, we have crossed this bridge before, with wearables and things to hide that, and patients go live life with it. So yes, we've overcome those challenges.
Wonderful to hear. This is one that is personal for me, but also for other people here in the audience. Can a traumatic brain injury influence or cause something like Parkinson's? And not cause, but have an influence or an causation?
Yes. There is evidence to support. I will be honest with the audience, I'm not familiar with literature that shows a one-time concussive event. One time falling off a horse, ladder, knocking yourself unconscious when you were 12 years old. I don't think that this is what we see is through repeat head trauma, that these are football players or boxers or athletes of some sort, that the brain does not like to have repeat concussive injuries, not even necessarily with loss of consciousness, but we do see in general traumatic brain injuries, which is colloquially called concussions, with or without loss of consciousness, do raise risk of Parkinson changes.
Thank you. Yeah, someone who had 4 concussions as a child, that is something that weighs heavily on my mind. We talked about supplements and other diet and things like that. Melatonin, probiotics, things like that. Are those things that we should consider and talk with you about?
Yes, always talk to, send me a message or call, if you're going to start something and you're not sure, because a lot of patients are taking blood thinners. They may be taking heart medications. They may be taking antiviral medications. They may be taking something that, we're thinking about Parkinson, but there's other things we've got to keep an eye on. And some of the supplements can cause clotting issues or stomach upset or weaken the effect of your heart medication. So we need to be cautious. So either me or primary care to discuss that. In select cases with symptoms, as again, as we say, we come in and review what symptoms are going on. If we see sleep changes, melatonin may play a role, in particular with what we call REM sleep behavior disorder, which is 80% of patients who have Parkinson changes may at times act out their dreams, yell or talk or move in their sleep. If it's coming in clusters and frequently enough, then recommendation may be made to start melatonin. Some doctors believe in taking a B vitamin supplement. We've got to be cautious of having super B complex, and too much B6 can cause numbness and tingling. So not everything is benign. But again, I advocate for a more tailored approach instead of one size fits all. Probiotics included as well.
Thank you. Really, really helpful for me, and I'm sure for a number of people in the audience. We will have a couple of minutes left here, so I would like to just close out by thanking both of you for participating and being here, but give you the floor to share anything that you want to, being able to educate us all with. Dr. Shields?
I think the idea of brain surgery, especially in an elective capacity, is really scary to patients. I think this is a great forum for people to talk to other people maybe who have had it or made the decision, because I think once people go through it, it kind of demystifies the process. And you realize a lot of patients say, I wish I had done that sooner. And so, it's as far as brain surgery goes, it's pretty minimally invasive. It's pretty low risk. And I encourage you just to, consider it as an option if you're a good candidate, because, medication can do a lot, but I think DBS is a wonderful option for Parkinson's patients. Desert is getting a new MRI scanner that is going to be capable of MRI-guided focus ultrasound.
That's wonderful.
So that should be, I think they're installing it, but like, you know how that goes. It'll probably be in the next year or something like this.
That's a wonderful, wonderful a thing for this community to have. That's great.
Wonderful news. Terrific news. I would echo what Dr. Shields said. We have a window generally. So we don't want to be getting ahead of our skis, but we do want to take advantage of options as they present themselves. And deep brain stimulation is a powerful tool in the toolbox, as is focus ultrasound. And in general, I would just say keeping Parkinson's in the back seat is the goal. So it's about quality of life. I think diet and exercise, take your medications, follow up with your doctor, stay involved in the community, try and stay active. And I appreciate, again, the opportunity to get together with this really amazing community. And those stories, again, as we share, it's a demonstration of resilience and faith, and I think it's a wonderful thing and reinvigorating for us. So I appreciate the Parkinson's Resource Organization, the Michael J. Fox Foundation, and of course the communities for being here. And Dr. Shields and Ethan, thank you.
Thank you all very much, and appreciate your really good attention. Thank you.